Alrighty, welcome to tonight's webinar. My name is Lee and I am the host of tonight's event. Your video and audio have been disabled so we cannot see or hear you. If you have questions for Dr. Rueb throughout the webinar, please type them in the chat feature at the bottom of your screen and we'll direct questions to Dr. Rueb during our Q&A session at the end. Please note all questions will remain anonymous. We can only answer general questions and cannot utilize this setting to diagnose your condition. Towards the end of the presentation, you will see a poll on your screen. Please answer the 3 questions. This will help us understand how the event benefited you and help us with ways to improve. Tonight's webinar is presented by Dr. Jessica Rueb. She will speak about bladder dysfunction, the common symptoms, patient's experience, and treatment options that might help you regain control. Without further ado, I'd like to introduce Dr. Jessica Rueb.
Hi, ladies. Thanks so much for joining me tonight. This will be a review for some of you, but some of you have not heard this type of information before, so hopefully you find it helpful. So we're going to talk about the regaining bladder and bowel control and the treatment options available. This is one of my, let me make sure I can go forward. Yeah. Um, this is my background. I'm a double board certified urologist and urogynecologist at Southern Urogynecology currently, and I've been in Columbia now going on 6 years, so it happens fast. This is one of our disclosures for tonight. And one of the top reasons that I like to do these type of talks is because people are so hush hush and unaware about how common it is to have bladder and bowel symptoms and really how disruptive it is to your life. And when I say that conditions are common, what I usually hear of why people didn't bring it up sooner is because they considered this a normal part of aging or just part of being a woman or something, something that was a result of childbirth or things like that. And although these conditions are really common, that doesn't mean that we have to live with them. And that's a distinction that I really want to make clear to women. And I want women to talk about this and realize that there are options out there. These conditions really affect our quality of life. If we don't have good bowel and bladder control, it limits our ability to be as physically active as we want, to be as social as we want. When you have to plan your day or your trip around your bathrooms, that really limits what you can do. And the psychological burden of that, of the embarrassment and fear of always thinking about that is really hard for women. And it's really unfair considering all that we've done to bring life into this world. So, I think even something people don't talk about is how much it affects your sexual health to be intimate with someone when you're concerned about how you're going to control your bladder and bowels is really difficult. And even our work and how our household runs when we're being disrupted from our daily jobs to have frequent bathroom breaks that other people aren't have, it starts to feel like people are looking at you like you're not pulling your weight. And having the household be full of incontinence products like bed sheets and pads and diapers, that really takes its toll. And all this together is why these conditions really affect our quality of life beyond just that initial leak. So let's talk about more about of why understanding the bladder and bowel conditions and why these occur. So the first ones we're going to focus on is overactive bladder, urinary retention, and fecal incontinence. So let's go through each of those. So overactive bladder refers to that sudden urge to urinate that you can't ignore and often leads to you urinating frequently, and even leaking or having a loss of urine on the way to the toilet. That's urge incontinence we refer to as. It's really a condition that is more so about the functional change of your bladder, not always the anatomy. You may have perfect position of the bladder and perfect support of the bladder, yet you have functional changes of your bladder where the bladder is now overactive. And that results in you urinating frequently, hourly, more than 8 times a day is by the definition, urgently, and losing urine on the way to the toilet. Often people describe this as my bladder has a mind of its own. When I pull into the garage or get my key in the front door or hear running water, all of a sudden my bladder went from 0 to 60 and I feel like I'm about to pee my pants. These are all very common symptoms of overactive bladder and can even contribute to how much we awaken at night to pee. Although many patients who have discussed this with me are disappointed to hear that it actually is normal to wake up a couple times. So I can't promise you perfect sleep like we once had, but but if you're having daytime and nighttime symptoms and you're waking up more than 2 times, then yes, overactive bladder may be playing a part here. So what's the normal function of the bladder? The bladder's job is to store the urine and empty it at the right time. So when we're not trying to pee, our bladder muscle is supposed to be calm and stretchy and allow that bladder to fill up and distend with urine. Meanwhile, our urethra is supposed to contract and squeeze so that it keeps that nice watertight seal and prevents leakage from happening when we don't mean to. Our pelvic floor contributes to that as well, and that's the muscle at the base down here. When you are ready to pee, so what's supposed to happen is your bladder is supposed to give the message to your brain and say, hey, pretty close to full down here. How about we head to the bathroom? And you're supposed to be able to say, well, I'm in line at the grocery store, can't exactly step out of line. Let's wait until we're closer to the bathroom. And your bladder is supposed to listen to you. But what happens with overactive bladder is that connection is lost and that bladder just decides for itself it wants to go. So when it empties, the bladder muscle is supposed to contract after it gets permission from your brain, contract down and squeeze the pee out of the bladder. So really, when you're peeing, it's coming from your bladder muscle, and that bladder muscle is supposed to contract all the way down, like a deflated balloon, if you will, like when you take the air out of a balloon and it deflates back down to its small size. And then your urethra is supposed to open up, and your pelvic floor muscles are supposed to open up and basically open the door so that the pee can come out. Many of us have gotten dysfunctional with our peeing, where we start peeing by squeezing our belly muscles and pushing it out. But really, you're not supposed to need to do that. Your bladder is supposed to do the work, and you're supposed to sit and relax on the toilet and let that bladder squeeze the pee out. When that's not happening correctly, in either the storage or the emptying, that's when we are having bladder troubles. So retention is one of those things that can happen, and that's an inability to empty your bladder. And people with this condition often feel like they have a really hard time starting their stream. They're sitting there for a while. That's called hesitancy. And that when they pee, they're peeing a small amount and they may not feel completely empty. And then they have to come back again and pee another small amount in order to try to empty their bladder all the way. You can also notice that your urine flow is not the big whoosh waterfall that it used to be. It's slow and just drips and does not have as good of a stream as it used to. And when you don't feel it, you don't feel totally empty, you can feel some more bloating or discomfort from having that partially full bladder afterward. So if you're not storing your pee the way we're meant to, that can be overactive bladder. And then if you're not emptying the bladder like we're supposed to, that can be underactive bladder or urinary retention. So, what about fecal incontinence? So, fecal incontinence refers to the loss of stool and that can happen with an urge, and that's called fecal urgency or urgency fecal incontinence. And so, much like the bladder, you can get a sudden urge to have a bowel movement, and if you don't go to the bathroom immediately, we can have a loss of stool without permission. Passive fecal incontinence is leakage of stool that can happen without any awareness. We didn't get any warning signs. We just go to use the restroom later and there's some stool in the underwear, and that's more passive fecal incontinence. So what's happening here? Well, what's supposed to happen is much like the bladder. These are actually shared nerves, by the way. We have nerves to the bladder and to the rectum. And when your rectum is full, that rectum is the end of the colon. When your rectum is full, you have monitors that tell the rectum that it's stretched, and that then sends a signal to our brain and say, "Hey, that rectum's pretty full. Why don't we head towards the bathroom?" And the bladder and the brain tells back to the rectum, "Yes, now this is a good time," and sends the nerve signal to help coordinate the rectum squeezing down and eliminating all the stool, and the muscles around the rectum, so that's our sphincter, our pelvic floor, to relax, to let the door open and let everything out. So it's supposed to be this coordinated effort, and the key is that the rectum and the bladder are both supposed to get permission before that happens. Um, and when that doesn't happen, it can lead to some very embarrassing and upsetting situations. So the important thing to hear in this webinar is that there is treatment available to help you get this bladder and bowel control regained. The When you come and see us in the office, we're going to walk you through what's called a care pathway. So there are steps to take in order for us to make sure we're leaving no stone unturned. And it starts with you helping us establish your baseline. What is your symptoms like at home? So that's one thing in preparation you can come to with your doctor's office when you discuss this type of scenario, is already think about, let's see, how many times do I pee? How many times do I not make it to the toilet and have a leak? And how many pads do I need to change? What is my stool consistency like, and how regular has that been? Really, that gives us the starting point, and help us realize what's realistically possible. And then after our initial discussion of symptoms, sometimes it helps to actually write that down and do more what we call a diary, where we're having you journal and say and write that down and really quantify that. And then we may have more evaluation or tests to do, certainly treatment options to be discussed. And then if typically we start small with the more conservative things. And if we're not seeing improvement, we continue into advanced therapies if needed. So overactive bladder, urinary retention, and bowel incontinence all have the initial more conservative treatments and initial treatment options, followed by advanced treatment options if we're not getting the results that we want. So an overactive bladder, the first thing we'll talk about is what basically I call it my homework for you. So what do I need you to do? So there are lifestyle changes, fluid modifications, and bladder retraining essentially to try to help your bladder be able to handle the changes that it's been through. So let's actually start at this number 2, lifestyle changes. So when you have an overactive bladder, think of your bladder as hypersensitive, and it cannot tolerate what it used to tolerate earlier in your life. So there is an adjustment that needs to be made. I want you to be able to drink enough fluid to stay hydrated, keep your kidneys healthy, and help prevent constipation, UTIs, and kidney stones, and all of that. But you also can't really chug fluid anymore, overdo it with fluid, or dehydrate yourself, because all of that will make it worse. So instead, I'm going to guide you to do kind of call it the Goldilocks, the just right. I want you to drink enough fluid to stay hydrated, but not so much that you're overwhelming your already sensitive bladder. So a good goal range is about 48 to 68 ounces of hydrating fluid a day. Doesn't have to be water. If you're not a water drinker, can be other type of flavored hydrating drinks. But the hydrating fluid needs to be the focus. If for reference, 48 to 68 ounces is 3 to 4 regular size 16-ounce bottles a day. We want you to drink that fluid slowly, sip on it throughout the day. When you have that overactive, hypersensitive bladder, if you chug a bottle of water and your bladder suddenly stretches out and distends with the fluid rush, it's not going to like that. It's going to go into the urgency and have a leak. So instead, I want you to sip on water, and during the working hours, 7 a.m. to 7 p.m., making sure you stop fluid well before bedtime. The goal is 4 hours if you're getting up in the middle of the night and you want to not do that. You want to stop well before bedtime so that you make sure you're not peeing into the night. And then we always have to talk about your bladder irritants. So bladder irritants are unfortunately all of the fun drinks, coffee, sodas, teas, alcohol. All of those drinks have a diuretic effect. They make you make more pee, and they also have an irritant effect, and they make you have more urgency, your bladder more likely to have a spasm. So I'm not telling you can't have any fun in your life or that you have to give up coffee, because I can't give up coffee. But how about we just make a compromise and get to 2 cups a day? Like 16 ounces total is a reasonable amount that I can work with you. But unfortunately, anybody with overactive bladder, if you can't limit yourself in the bladder irritants, you can outdrink every single treatment I have to offer you. So that is a point of contention where we have to find a middle ground. Okay. That'll be some homework. Um, Beyond that, we want you to get in the rhythm of emptying your bladder regularly, not doing what we call bathroom mapping, where you pee at every bathroom you see just in case. Unfortunately, when you do that, you're teaching your bladder that, hey, we pee at every bathroom we see. And then the bladder starts reacting to smaller and smaller volumes. So, we also don't want you doing the extreme of holding it for an 8-hour shift. That's not good for your bladder. That will cause chronic stretching of the muscle and can deteriorate the muscle over time and actually make you more prone to both of the bladder problems, overactive bladder and retention. So I need you to find the Goldilocks, the just right of, not too frequent, not delaying too much. So a good range for that is every 2 to 4 hours trying to pee during the day. And when this bladder training, that's part of that, is called timed voiding. The other part of that is trying to teach your bladder not to over respond. So when you feel that keys in the front door and you have that strong urgency, I actually want you to wait, stand still or sit still, practice your deep breathing, distract your brain, squeeze those Kegel muscles of what we call quick flicks, where you squeeze, release. And that basically slams the door on the bladder and tells the bladder, hey, we're not peeing right now. You're going to cut it out. And what you're doing is you're wading through a contraction. It's a contraction of the bladder instead of the uterus, but it's a very similar experience. Your smooth muscle is squeezing down just like it did during a contraction with a baby. And if you let that contraction pass you by, it will release you. And once your bladder is calm, that's a good time to get up and go. Every time you win one of those battles, you have taught your bladder that you are the boss and it should listen to you and wait for your cue. So bladder training is not easy when the bladder is really out of control. But I think with the fluid, with managing your fluids and introducing things like medications, you can certainly see a lot of progress. And it's still an important part of gaining better control of your bladder. The next thing, or maybe at the same time we might try, is medications. These medications are aimed at relaxing the bladder muscle so that you can hold more fluid and reducing the number of spasms that you're having to improve your control. The medications, there's a lot of them, and there's two main categories. The anticholinergics are the older medications that have better insurance coverage typically, but can have more side effects. And then there's these other group of medications called the beta-3 agonists that have less side effects, and typically are more tolerable, but because they're newer, some of the insurance companies don't cover them well. So it's a little bit of a battle between insurance companies and what you and I want. And ultimately, when it comes to medications, it does sometimes take some trial and error to figure out what is effective for you, has low side effects, and is reasonable as far as the cost and long-term use. So sometimes it takes a little having patience with us as we try to help you navigate that system. Um, the but the thing to remember is that we're not all about medications. If the medications aren't a reasonable option for you, I obviously don't want that for you either. But in order to move forward in our treatment plan, we at least have to try them. What's beyond medications is there are advanced therapies that work at the nerves. And one thing we can do with the nerves is use Botox in the nerves of the bladder. Botox is the same toxin that we use in our faces and all sorts of things to smooth out the wrinkles. So when we inject a Botox into the bladder, we're essentially relaxing that bladder and forcing it to increase that capacity and reduce the spasms or contractions it's having. So kind of smoothing out the wrinkles inside the bladder. This is a in-office procedure, but it does have to be repeated just like Botox anywhere else. With repeating can be anywhere from actually 3 to 6 months, I would say. 9 months is a little bit more of an extreme, and I think some women are definitely having to repeat it at 3 months. And then there's nerve stimulation. Nerve stimulation for the bladder can come from our ankle. The ankle nerve at your ankle, called the tibial nerve, actually meets up with your pelvis nerves deeper in the body. And so you can stimulate the nerve to the bladder from your ankle. Nowadays, there is this is describing an older system that was called PTNS, or percutaneous tibial nerve stimulation. With that, we use what's essentially looks like an acupuncture needle and what looks like a TENS unit, and adding stimulation to that acupuncture needle. I have done this to myself. It does not hurt. It feels like a tingling on the bottom of your foot, and it may make your toe move. And that stimulation for 30 minutes, 12 weeks in a row, can help you improve your bladder function. So, main limitations to this are, of course, if you have to do this in the office every week for 12 weeks and then monthly after that, that can be very taxing, and not a lot of people have time for that. So there is an implantable version of this these days. And there's actually a couple different versions that are slowly becoming available, although there is some coverage issues for insurance. So there are options here. But comparatively, we're going to talk about the sacral stimulation, the ankle stimulation. Think of this as the country road to the bladder, versus the tailbone stimulation is like the superhighway to the bladder. So if you're going to take the country road to the bladder, you got to expect that it's going to take some time to really reach maximum effect. And it's not as direct as when we go through the tailbone. When we go through the tailbone to the bladder, you're on that superhighway and you can see effects the next day. So it is a little bit of a different expectation in far as the treatment plan going forward. Retention. So shifting gears here, let's talk about retention. So urinary retention is a tough one because technically for women, there are no approved medications that are going to help your bladder empty better. Instead, when we are first diagnosed with that we know we don't empty our bladder, you essentially have to start treating your bladder differently and be hyper aware of making sure you're emptying as much as you can. So when it comes to not emptying the bladder completely, I'm going to tell you that I want you to make sure that you're peeing by the clock every 2 to 4 hours during the day. That when you pee, that you're doing what's called double voiding, peeing twice in a row, that you're doing the lean forward, tip the teapot, see if you can get some more pee out, that you're working on your pelvic floor muscles to try to open that door as much as possible, relax that muscle so the bladder can do the work. Um, and really see if you can manage your bladder in that manner just by taking the extra time, making sure you're as empty as you can be. Alpha blockers are a medication that's typically used in men to relax the muscle in the prostate. It could be used off-label in women to relax the muscle at the sphincter, at the bladder neck. But again, off-label can't always tell you that it's going to work well. That's really not its intention. So beyond medications, most patients that are not managing their bladder well, that let's say are having urinary tract infections, or they just constantly feel like the bladder, emptying the bladder is kind of taken over their life. The way that is more realistic to deal with this is you doing an intermittent catheterization. And what that means is passing that tube through the urethra yourself to empty out the bladder every time that you need to at regular intervals throughout the day. And that will actually decrease your risk for UTIs, make sure you're feeling more comfortably, and give you a lot of control back because you can make sure that every time you pee, you're actually empty. So yes, that's not what everyone wants to hear. Of course not. But it's something that if you had to do it, I'm certain that we could get you accustomed to that, and that would give you back some control of your life. There beyond that intermittent catheterization, that there are surgical procedures that insert a tube, let's say over the bladder into the bladder dome to help empty the bladder, or more serious surgeries to try to provide some relief. But this is a really tough problem, and unfortunately, there are not as clear options going forward that are acceptable to most people. So switching back for the bowels for a second here. So when it comes to fecal incontinence, this is also very multifaceted. The bowels you can have bowel incontinence for a number of reasons. You can have sensitivities to things that you eat that your bowel can no longer handle. The very classic example of that is a lactose intolerance. A lot of us, as we age, develop a lactose intolerance that we never had before. And that's a loss of an enzyme that allows us to break down that material. And instead, when you have something with that in there, you know about it because you have diarrhea. There are other things that can also irritate people's bowels as far as fatty food, sugary food. Fake sugars are a big one, that like the sugarless gums have a lot of the sucrose in it that can give people diarrhea as well. And then the things that our body has been through, like a gallbladder surgery, is a very classic example. When people have their gallbladder removed, instead of their gallbladder squeezing out a little bit of bile when we have a fatty meal and we need to digest it, the liver is just kind of dumping bile into the bowel. And bile is a laxative. And so when you have a lot of bile dumping into your bowel, you get diarrhea from that. So anytime you have a fatty meal results in diarrhea, and that's actually from the bile. So there are medications that you can consider in that scenario. There's a medication called cholestyramine that the GI doctors can talk to you about, and that can help sequester that bile and reduce that effect. If you are having diarrhea, that's considered more irritable bowel syndrome, and you can't really link it to any specific food or drink. What you'll often hear from GI doctors is go ahead and take that Imodium in order to regulate your frequency of your bowels. Now, a lot of people don't want to live on Imodium, and that's understandable, but that is a very common piece of advice that's like medically acceptable. So that's really the medications is Imodium and cholestyramine. And then dietary changes is avoidance of anything that sets you off. you can also strengthen your pelvic floor muscles. Your pelvic floor muscles are important for holding that stool in, just as it is for holding the urine in. And if you're having passive incontinence, you're not feeling the urgency, it's just slipping out. One thing you probably do want to try is making sure that your muscles are strong and you have good tone that's helping support that rectum. So pelvic floor can have a role in this as well. The right side here of as far as the pessary or anal inserts, or PTNS, I would not say that any of those three are common practice at all. There's very uncommon situation where a pessary would help. There aren't many people that are doing anal inserts, and this is not in PTNS. The acupuncture one I was describing is actually not approved if by most insurances for use in fecal incontinence. So really, when it comes to fecal incontinence, we're going to focus on the left side of the map here. And again, these are interventions that are not very common as the bulking for fecal incontinence. And then a surgical intervention is a more extreme situation. Those are people that are having such a hard time that you're considering doing what's called a colostomy, where we're rerouting your colon into a bag. And that's obviously something that no one wants to do or proceed lightly with at all. But if that's what it takes to give you back your quality of life, then that is certainly an option for some folks. And I definitely have seen that where that actually makes more sense for a person than how they're currently living. So for all three of those scenarios, overactive bladder, retention, and fecal incontinence, they seem so different, and yet they all are treated with sacral neuromodulation. And why is that? So going back to the nerve under the tailbone is that superhighway, and it goes actually to the bladder and the bowel because those nerves are shared higher up. So right under the tailbone is where those nerves are shared. And when you modulate the activity of the sacral nerve, it helps restore that communication between the brain and the bladder and the brain and the bowel. And I essentially explain it much like a pacemaker, where a pacemaker is normalizing the rate of your heart. This type of therapy with neuromodulation is normalizing the activity of the bladder or the activity of the bowel. And so all this one therapy can help with all of these things. So people that have multiple of them, that they don't empty well and they have urge incontinence, or they have fecal incontinence and they have urge incontinence, that's the one time in my care that I'm really going to tell you, gosh, you got to look at this thing, because this is what really is going to do both. With one device, one same nerve, you can treat all of these conditions. This therapy is trialed typically it's often in an office-based setting. And the trial, we'll walk you through that, but that essentially is trying that therapy on for size, doing a test drive, driving it off the lot. And that is a requirement that we need to get this cleared and covered by your insurance, because this is a covered procedure as long as we've done the steps. But we do actually need to prove that it works. And I like that. I like that about this therapy, because then you feel confident, I feel confident, and then yes, we have the insurance knowing that we've tried this out and it works, but we know that it's going to work. A successful trial is saying that you have at least a 50% improvement in your symptoms is the very minimum that we need to move forward with this trial. And so to do that trial, I have you a diary and actually write it all down so we can compare apples to apples and make sure that we are meeting success that you and I are comfortable with. And that's how people choose to do the long-term implant. The long-term implant, lasts for 15 or 20 years. And as far as the battery life, and the lead is hopefully a lifelong battery. And this implant is placed in an outpatient surgery. That is a same-day surgery, a brief activity restrictions of a couple weeks until that incision heals, and then you're back to your normal life. But immediately after surgery, you begin your new chapter where you have a therapy that's we know already works for you because we tested it, and you get to start this new chapter of your life with bladder and bowel control. So it is one of these therapies that I love to do because I see how well this works for patients. It really improves that bladder and bowel control and restores that communication. That one study showing 93% of people had improved bladder control at 2 years. So we're talking long-term therapy. And actually, the fecal incontinence patients are the most likely to improve. And so given how hard that one is to treat, I think that's a huge advantage of this therapy if you have fecal incontinence. The first step towards this therapy, like I said, is going to be the doing a test. This is the use of a temporary lead near the nerves. We're going through your tailbone. And we're stimulating that nerve and taping a temporary battery to your back, and you're going to track your symptoms for 5 to 7 days before the test and during the test to make sure that we're hitting improvements. And you'll be able to see firsthand what kind of effects you can get. And then this is the implant that we place. The F15 is what we call a recharge-free system. That means you don't have to recharge that battery. The little remote here that you get allows you to go up and down on the therapy or turn it off if you need to get an MRI, for example. You don't have to mess with that all the time. It's constantly on and constantly pacing and neuromodulating that nerve. If you need to make an adjustment, that remote is available, but you don't have to charge the remote either. Which is really great. This battery is intended to last a long time, at least 15 years, but it can go longer depending on kind of how we're running it. There is also a rechargeable version that's on the left here, the R20. That one is a 20-year battery life, but you do have to recharge it every 6 months or so. And that little white puck they have here is what you would recharge it with. You would just place that white puck over your skin and it would communicate and recharge through your skin of the battery to recharge that battery. And that would allow it to last more than 20 years by recharging it. The difference between these two are their profiles. One is smaller than the other. So for my thin patients, patients that we're putting it like an upper butt cheek area. So if you don't have a lot of love handles like some of us, well, good for you. And you might want to try the smaller ones. So we'll talk about that and see what fits your body type. The MRI status, so that's been a big question in the past. Nowadays, all of these are MRI compatible, and they are approved for the most common MRIs, which is the 1.5 and the 3T full body MRI. So that no longer has to be a question. You do have to turn it off, so you have to bring your remote for that session, but then you can turn it right back on. So long-lasting improvement. This is over 90% of patients that would choose this therapy again that are satisfied at 2 years and had an excellent result from their trial and from the ultimate therapy. And that's in urgency, urge incontinence and fecal incontinence and retention. So and of course, there are always risks to anything we do, and we can talk through that for you specifically. But what I want you to hear is this is a very reliable result that you get to try out first and know that you're gonna get the results that we got at the trial. So let's shift gears in the last 20 minutes here and talk a little bit about the other urinary condition called stress incontinence. So stress incontinence, this is different than overactive bladder. It's not that you're under emotional stress, it's that you're having a physical pressure outside your bladder when we cough, when we laugh, when we sneeze, when we jump up and down. And that pressure on the bladder challenges the urethra. And if your urethra is not well supported, not strong, or you have ligament weakness, you can have that urethra open and jump back and forth. We call that hypermobility, where then the urine gets into the urethra and you're leaking pee out. So this develops really because of a support problem. It's the loss of support around the urethra that causes it. And that is a common effect of childbirth, of hormone changes, of changes in our weight and the chronic heavy lifting that we do, or coughing, that all can make an impact on our ligamentous support and the strength of our urethra, and our pelvic floor. And age, menopause, family history, obesity, all of that adds to our risk for stress incontinence. So again, going back to the normal function, focusing on the urethra this time, our urethra needs to contract and stay closed when we're not trying to pee, and then it needs to open up, and our surrounding muscles, including our sphincter, including our pelvic floor, need to relax and open to get the pee out. And when that doesn't happen correctly, we can get stress incontinence. Stress incontinence is incredibly common. That's the one that's my huge pet peeve of people saying, well, this is normal after childbirth, right? Well, yeah, it's super common. Like 50% of one in two are going to have some leakage. But does that mean that we all have to live with that? No. There are options for this. So what are options for stress incontinence? Nowadays, we've gotten pretty fancy with our options for stress incontinence. If yours is rare and you're okay doing some absorbent undergarments, gosh, they have that nowadays. They have underwear that absorbs the pee up, that you don't have to wear a pad. And if that's happening, once in a while, maybe that's a solution that's satisfactory to you. We can certainly do things like not drink a lot and empty our bladder before we work out. I would still avoid doing like caffeine sodas and energy drinks right before a workout, because then you're kind of setting your bladder up to be irritable and more likely to have that urge incontinence in addition to your stress incontinence. Um, and then the base of the treatment when it comes to stress incontinence is our pelvic floor. So we all have heard about Kegels at some point. Most of us heard about it right after babies, and we may have done it right after babies, and then we forgot, and then we didn't do it again. So we could all do better about doing Kegels. The pelvic floor is a muscle, and like any other muscle, if you work at that muscle and you practice that muscle, it will improve. But if we forget about it and never address Kegels again, then you're going to get more weakness there. So what you should be aiming for is to be able to do 3 sets of 10 Kegels a day. So a Kegel, a good Kegel, is squeezing your pelvic floor muscles so it feels like you're picking up your vagina, you're picking up your rectum without using your buttock or your thighs to supplement. So that joke about I'm doing Kegels and nobody knows, that's how it should be. You're not moving, only the internal muscles are moving, and nobody can tell what you're doing. We could all do better about doing regular Kegels. Um, Another way to sneak in some Kegels, I say, is that when you're doing things like what's pictured here, this is a glute bridge. When you're trying to squeeze and improve the strength of your core muscles in things like a glute bridge or a plank, you're actually squeezing your Kegels at the same time because those muscles are connected. So it's called core to floor. When you pick up and squeeze the core muscles, you're also squeezing the Kegel muscles. So if getting in the habit of doing regular those type of exercises can also improve that strength. Um, and then nowadays they have vaginal inserts that you can buy yourself on Amazon or all kinds of things. Some of the fun ones of one of my favorites is called the PeriFit. It is a vaginal insert that you place into the vaginal canal, and then you have an app on your phone that when the harder you squeeze, you make a butterfly raise up in the air on your app on your phone and pick the gold coins out of the air. So, they make it fun and interactive. So I love that about it. So that is something that you could buy on your own. There are a couple different companies that do that, and whatever it takes to be more proactive and use it more frequently, that's what's recommended. There are nowadays pelvic floor physical therapists are much more common, and a lot of them are covered by insurance. So you could see an in-person pelvic floor physical therapist. There are even some companies that are approving, and insurance companies that are covering a virtual physical therapy session. So there's one group called the Leva that it comes with a pelvic floor wand, and it's like pencil thin, soft, that you place vaginally vaginally, and then you squeeze on that wand, and that information is collected in your app, and then it is shared virtually with a real person, a PT, that then calls you once a week, and you guys have a virtual appointment where you discuss how you're doing and how you can do it better. So having that accountability and someone actually measuring your improvement can really make a bigger difference, especially for people that feels like I've done Kegels. I don't think I'm getting anywhere with that. Well, talk to a professional that really does this for a living and make sure that you really have done all that you can to strengthen that muscle. Um, Beyond strength training, so what else can you do? I forgot about this lifestyle changes. One piece of advice is to lose weight with both overactive bladder and stress incontinence. It actually, even a 10% weight loss can improve your bladder control. Now, that's easier said than done, especially when you feel like your incontinence is keeping you from being as physically active as you want. So, that's certainly not something we harp too much on, but just as another motivator to what we're all trying to do and be healthy and be at our ideal weight, it can make a difference. And then when we've all experienced the coughing that causes the leakage as well. So if you can do things like quit smoking, that can help with a chronic cough, more power to you. That would really help in a lot of ways. Beyond the physical therapy and the strengthening and the lifestyle changes, there are non-surgical treatments, and that is one style of that is called a vaginal pessary. It is a medical insert that we place vaginally to support the urethra and the bladder. And that helps kind of give that urethra an extra push from the inside to help it not move so much and fill with pee as we're active. So that can require some measurements and repositioning and kind of trial and error to see what fits comfortably. But that's certainly something I could help you with if you feel like that's your ideal option. I think that works really well for people that are like only leak when they are do certain types of activities or have a cough or cold. And if they can just use the pessary for those times, they're pretty happy. Beyond that, it's more surgical options. There are techniques called like the bladder neck suspension or the copo suspension. Both of those are kind of outdated and no longer really used. What is the gold standard is still the mid-urethral sling. That is still a very common and probably the most common procedure that Dr. Prezella and I do. This is a mesh hammock that is placed through the underneath the urethra, anchoring into the pelvic muscle called the obturator muscle here, and that helps hold up the urethra and give it like a backboard so that it's not jiggling and moving up and down and filling with pee. So this is a very a permanent option. It is the highest percentage improvement for any one procedure when it comes to stress incontinence, and it is still considered the standard of care. This is not a mesh that's been removed from the market. It is one that is placed vaginally, but very safely and purposefully underneath the urethra to give you that extra support. It's an outpatient procedure. And of course, because we're using mesh, we are going to talk through the risks involved and what that looks like. We oftentimes are going to do more bladder study to make sure that this is the ideal option for you. And it is going to come with some time off. So in order to heal from this, it's a minor surgery, and most people feel pretty good within a week after surgery, but you may be restricted for 6 weeks, depending on how long it takes for you to heal, in order to let that mesh become a permanent part of your body where your body is growing into that mesh. And that's the idea. It's going to be a permanent structure to give you that support that you're missing around the urethra. And we do typically often tell people that if you're not done with family planning and considering another pregnancy, you may want to wait until after the pregnancies before you go through a procedure like this one. And then mid-urethral bulking. So this has actually become one of my favorites. I think it's one of the best inventions that has affected the urogynecology in the last decade. So urethral bulking is with Bulkamid has been a very reliable option for an alternative to mid-urethral slings. Bulking, I like to call it my lip filler of the urethra. Lip fillers are really in these days. People usually have an understanding of what that is. This in the Urogyne world is not used in the lips. It is used in the tube itself, in the P tube. I'm injecting the hydrogel underneath that lining to put pressure and allow your urethra to create a better watertight seal so that when you're up and walking, that the pee is not leaking out. So we're bulking up those walls. It is a hydrogel that is majority like 98% water and a polymer that's keeping it together. So it's a very safe agent that's being used. It stays where we put it, and it is up to 7-year data is what we've looked at. This can be performed in an office setting or a procedure setting without the use of anesthesia. And the procedure itself maybe takes me 5 minutes. Now, I usually have my patients come in for 30 minutes because I'm going to try to get you as numb as possible. We typically do not use anesthesia for this unless a patient really wants that, because it is so quick. It's kind of on the same level of discomfort as putting in like IUDs, for instance. Quick, still some discomfort there, but certainly something you can go through for the payoff. And within 5 minutes, I'm able to plump up that urethra to where you can see the results immediately. And the best part about this is there is no downtime outside of that day. I'm going to tell you not to work out that day so that you don't have more bleeding than you need. But beyond that, most people are right back to it and can go back to exercising the next day. Um, and you can have children. This you're not excluded if you're not done with your childbearing years. You can certainly do this, and now. And there are some folks that may still end up getting a sling later or want a sling later, and we're not burning that bridge. We could still do those things if you need more support. But we have seen a great result from the bulking, and that honestly has become one of my favorite procedures because of how well our patients do. So think of bulking as a safe and effective, minimally invasive procedure designed to give you that extra support in just a kind of outpatient setting with local anesthetic and with long-lasting relief of up to 7 years is what was studied. And we're on the cusp of that, of how long it's been on the market. So we're going to see, over time, what kind of longer even effect we can get. But very exciting therapy that I am grateful for to be a urogynecologist in this day and age because of this type of technology. So I think that brings us to the end. So let's see if anyone has any questions they would like to share.
Yes, thank you so much for that presentation. I'm going to stop the recording real quick and then we will get into the Q&A section.